Welcome to the Kanski lecture series, and it is the orbit part 7. And in this part, we are going to discuss about the tumors, lacrimal gland tumors. So, there are basically benign tumor and the malignant tumor of the lacrimal gland. The most common one is the pleomorphic adenoma, and then the malignant one is the lacrimal gland carcinoma. So, pleomorphic lacrimal gland adenoma is a benign tumor. Introduction. Pleomorphic benign mixed cell tumor. So basically it is a mixed cell tumor, so that is why it is called pleomorphic. Is the most common epithelial tumor of the lacrimal gland and is derived from the duct and the secretory elements including myoepithelial cells. So basically the tumor originates from the epithelial cells of the duct and another secretory element, myoepithelial cells, which are basically the secretory material. On histopathology, the inner layer of cell form the glandular tissue that may be associated with squamous differentiation and keratin production. The outer cell undergo metaplastic changes leading to the formation of the myxoid tissue. Young to middle-aged adults are predominantly affected groups. So young and middle-aged groups are affected. So basically we have two layers, the inner layer and the outer cell layer. So the outer cell layer is formed made up of the myxoid tissue, whereas the inner cell layers form the squamous cell differentiation and keratin production. So you can see this figure. Pleomorphic lacrimal gland adenoma A is showing histology showing glandular tissue and squamous differentiation with keratin production. So these are all keratin produced, and these are squamous differentiation and glandular production. So main difference between the benign tumor and malignant tumor is that in a benign tumor it is a painless swelling and it occur in a younger group, whereas malignant it is a painful swelling. So symptoms are the painless, slowly growing, slowly progressive proptosis or swelling in the supralateral lid, eyelid, usually more than a year duration. Old photographs may reveal an abnormality many years prior to the presentation. So there is a proptosis. Remember that the lacrimal gland is present in the supratemporal area. So whenever there is a swelling uh, or any kind of tumor, it will cause the infranasal dystopia. The eye will move inferior and nasal side. So there is an orbital lobe tumor and palpebral lobe tumor. The orbital lobe tumor presents as a smooth, firm, non-tender mass in the lacrimal gland fossa with the infranasal dystopia. Posterior extension may cause proptosis, ophthalmoplegia, and choroidal fluid. So whenever there is a posterior side expansion, it will compresses the nerve. It can cause the ophthalmoplegia as well. So palpebral lobe tumor is less common and tend to grow anteriorly, causing upper lid swelling without dystopia, which may be visible to inspection. Very important about the CT scan. The CT scan show a round or oval mass with a smooth outline and indentation, but not destruction of the lacrimal gland fossa. The lesion may indent the globe and calcification may be shown. So one important thing about the lacrimal gland adenoma is that basically it can cause the indentation of the bone, but it will not cause the destruction, and the outline is usually smooth and encapsulated. So if there is no particular smooth formation and the margins are very rough and there is a destruction of the globe, always think of the lacrimal gland carcinoma. So you can see this figure here. B is showing us the infranasal dystopia. So the eye is getting inferior and downward due to a tumor arising from the orbital lobe. B is showing eyelid. C is showing eyelid swelling without dystopia. D is showing eversion of the upper eyelid revealed the tumor, and E is showing the coronal CT showing an orbital lobe lesion. So how will you treat it? Treatment is with the surgical excision. So, treatment involves surgical excision if the diagnosis is strongly suspected. It is wise to avoid the prior biopsy to prevent tumor seeding into the adjacent orbital tissue, although this may not always be possible in context of the diagnostic uncertainty. Tumor of palpebral lobes are usually resected along with the margin of normal tissue through an interior transseptal orbitotomy. Those of orbital portions are excised through the lateral orbitotomy. So basically, one thing is that it is one of the tumor in which you avoid the biopsy, because if you do biopsy, there is a chance of tumor seeding in the surrounding tissue. That is why we tends to remove it completely and in with the capsule intact, so that there is no tumor cells that seeds into the adjacent tissue. And we remove the palpebral lobe tumor through anterior orbitotomy and posterior or orbital portion through a lateral orbitotomy. So what do we do is basically we inside the temporalis muscle is inside the underlying bone is drilled. For subsequent wiring, the lateral orbital wall is removed and the tumor excised include the margin of the adjacent tissue and periorbital. So if you suspect a tumor, you also remove some normal margin as well. The lateral orbital wall and temporalis are repaired. The prognosis is excellent provided excision is complete and without the disruption of the capsule. Incomplete excision or preliminary incisional biopsy may result in the seeding of the tumor into the adjacent tissue with recurrence and occasionally malignant change. So if the tumor is not removed properly, it can change into malignant transformation. So you see, this is a lateral orbitotomy. A is showing us the incision of the temporalis muscle, and B is showing the drilling of the underlying bone for subsequent wiring, and C is showing the removal of the tumor of the lateral orbital wall and the tumor, and D is showing the repair of the lateral orbital wall. Next is the lacrimal gland carcinoma. So lacrimal gland carcinoma is a rare tumor that carries a high morbidity and mortality. In order of frequency, the main histological types are adenoid, cystic, pleomorphic, adenocarcinoma, mucoepidermoid, and squamous cell. So I remember it with the APMS. So the carcinoma can be histopathologically, they can be of any type. They can be of adenoid type, they can be the pleomorphic type, they can be mucoepidermoid type, and they can be the squamous cell type. Histology shows the nest of the basaloid cell with numerous mitosis. The peak incidence is of middle-aged adults, so it occurs in the middle-aged adults. So this is the histology of the adenoid cystic carcinoma, showing the nest of the basoid cells with the solid and cribriform area. And B is showing us the dystopia, proptosis, and periorbital edema and epibulbar congestion due to extension involving the superior orbital fissure. And C is showing the coronal seating, showing contiguous erosion of the bone and the spotty calcification in the tumor. So diagnosis is a malignant mixed cell tumor present in 3 main clinical settings. So there are certain condition which predisposes to the malignant transformation. Is basically one of the things we discussed earlier is when there is an incomplete excision of the tumor lacrimal gland adenoma. So after incomplete or piecemeal excision of a benign pleomorphic adenoma followed by one or more recurrences over a period of several years with eventual malignant transformation, as a long-standing proptosis or swollen upper lid that suddenly starts to increase without previous history of pleomorphic adenoma, as a rapidly growing lacrimal gland mass, usually of several month duration. So basically it is showing that there is certain kind of proptosis, but suddenly it increases in size and there can be a new lesion as well. The history is shorter than that of a benign tumor. So benign tumor usually present with a duration of 1 year or more, whereas this present with a much less shorter history. Brain is a frequent feature of malignancy but also occur with an inflammatory lesion sign. Mass in the lacrimal area causing intranasal dystopia, posterior extension with involvement of the superior orbital fissure may give rise to epibulbar congestion, proptosis, periorbital edema, and ophthalmoplegia. So, whenever the tumor is progressing posteriorly, it will cause the optic nerve compression. It can cause other nerve compression. It can cause ophthalmoplegia. It will cause the proptosis as well. Hypoesthesia in the region of supplied by the lacrimal nerve, optic disc swelling, and choroidal folds will present with as well. So very important is a CT scan of it. CT scan shows a globular lesion with irregular serrated edges, often with the contagious erosion or invasion of the bone. So there will be the irregular edges of the tumor, and there will be the bony erosion as well. Calcification is commonly seen within the tumor. Biopsy is necessary to establish the histological diagnosis. Subsequent management depends on the extent of tumor invasion of adjacent structure as seen on the imaging. Neurological assessment is mandatory because adenoid cystic carcinoma exhibit perineural spread and may extend into the cavernous sinus, so it have the intracranial extension as well. Treatment involves incision of the tumor and the adjacent tissue. Extensive tumor may require orbital excenteration or mid-facial resection, but the prognosis for life is frequently poor. Radiotherapy combined with local resection may prolong life and reduce pain. Adjuvant intra-arterial chemotherapy and or brachytherapy may be utilized in some cases. So basically the treatment plan is excision. Sometimes a wide excision is necessary, like excenteration or mid-facial resection, plus with the radiotherapy as well, or you can give adjuvant chemotherapy or brachytherapy as well. So next is the neural tumors, that is optic nerve glioma, optic nerve sheath meningioma, plexiform neurofibroma, and isolated neurofibromas. So optic nerve glioma, so remember these are very important topics. The glioma is usually occur in a children, and it has an association with an NF1, whereas optic nerve sheath meningioma, it occurs in a middle-aged woman and it has a strong association with NF2. So optic nerve glioma is a slowly growing pleocytic astrocytoma that typically affects children. Median age 6.5 years. Histopathology show spindle shaped pilocytic hair-like astrocytes and the glial filaments. So there are glial tissues, and one of them is the astrocytes. So basically these are the supporting cells of the nerve. So whenever there is a tumor or abnormal proliferation in it, it can cause the pilocytic astrocytoma. And what will it show? It will show the spindle shape astrocyte and a glial filaments. The prognosis is unpredictable. Some have an indolent course with little growth, while other may extend intracranially and threaten life. Approximately 30% of the patient have associated neurofibromatosis type 1, and in these patients the prognosis is superior. So very important. So whenever the patient with NF1 present with optic nerve glioma will have a superior prognosis. A malignant glioblastoma is a rare but very poor prognosis and usually occur in adult males. So glioblastoma is a more malignant tumor, and it usually occur in a adult male especially. So what is the symptoms? There will be the slowly progressive visual loss followed later by proptosis, although the sequence may occasionally be reversed. So first of all, the patient will present to you with the vision loss, and that will accompanied later with the proptosis. Acute loss of vision due to hemorrhage into the tumor can occur but is uncommon. Proptosis is often non-axial with temporal or inferior dystopia. Very important. Basically, we tends to think that a optic nerve is basically lying just behind the globe, and if there is any lesion, it will cause the axial proptosis. But that is not a case in the optic nerve glioma. It will cause the dystopia as well, usually temporal or inferior. The optic nerve had initially swollen, subsequently become atrophic. So of course the tumor is compressing the optic nerve, so it will cause the optic nerve head swelling and atrophy as well. Optociliary collaterals and other fundus signs such as retinal vein occlusions are occasionally seen. Intracranial separate to chiasm and hypothalamus may develop. Very important, it have an intracranial extension as well. So what do we do? MRI. The MRI effectively demonstrate the tumor and may show intracranial extension if present. CT in patient with associated NF1 show a fusiform enlargement of the optic nerve with a clear cut margin produced by the intact dural sheath. In patient without NF1, the nerve is more irregular and show low density area. So very important is the difference of the CT. So in case of the glioma, there will be the fusiform enlargement of the optic nerve, and in a case of optic nerve sheath meningioma, it will have a tram track like appearance because the sheath is having the tumors. So this is the tumor. It is an optic nerve glioma. A is showing histopathology, showing us the spindle shaped. So this is a spindle shaped cells and astrocytes and glial filaments. B is showing proptosis with inferior dystopia. C is showing the optic disc atrophy, and D is showing axial MRI showing fusiform enlargement of the optic nerve. Treatment of all, as the tumor is intrinsic to the optic nerve, resection means all vision will be lost in the operated eye. So one of the very important, because it is surrounding the optic nerve, so if you wanted to remove the tumor, it will cause the resection of the optic nerve as well, so the eyesight will be lost. So there are certain things that you can do: observation, surgical excision, and radiotherapy. So observation may be considered in patient with a typical pilocytic astrocytoma on imaging whom the tumor is confined to the orbit, especially if there is a good vision and no significant cosmetic improvement. Serial MRI is important if this option is chosen. Spontaneous regression has been reported usually in NF1 but is rare. So in which condition will you do observation? If the tumor is static, if the patient has a good vision and there is no other cosmetic reason, but in that case you have to do the serial MRI for the observation as well. Surgical excision with preservation of globe is indicated in those with larger or growing tumor whose complete resection of the tumor can be achieved, particularly if the vision is poor and proptosis significant. A key goal is to prevent the chiasmal involvement, and intracranial approach may be necessary to achieve adequate resection. So whenever there is a chance that a tumor is separating through into intracranial to hypothalamus and chiasmal area, you can remove it, and you can also remove if there is a poor vision and there is a significant proptosis as well. Radiotherapy may be combined with chemotherapy for tumor with extension that precludes complete surgical excision, for example if it's spread to the intracranial region. So next is an optic nerve sheath meningioma. Optic nerve sheath meningioma is a benign tumor arising from the meningothelial cells of the arachnoid villi surrounding the intraorbital or less commonly the intracanalicular portion of the optic nerve. So you know that optic nerve has a few parts. It can be the intraorbital, intracranial as well. So you know that nerves are supplied by the three sheaths: the dura, the arachnoid, and the arachnoid and the pia mater. So basically the arachnoid villi has a meningothelial cells, and the proliferation of these cells cause the optic nerve sheath meningioma. So whenever there is the sheath of the sheath surrounding the optic nerve is basically enlarging and causing the compression of the optic nerve as well. We will see the triad as well. In some cases, the tumor merely encircle the optic nerve, whilst in others it may invade the nerve growing along the fibrovascular PL septal. However, about 2/3 of all the meningiomas affecting the optic nerve arise from the extension of primarily intracranial lesion. So sometimes it can be the extension from the primary intracranial lesions. That the tumor is basically intracranial and it is going into the intraorbital part of the optic nerve. Primary optic nerve sheath meningiomas are less common than optic nerve glioma, and as with other meningioma, typically affect middle-aged women. So it typically affect the middle-aged women. Histopathologically, meningothelial irregular lobules of meningothelial cells separated by a fibrovascular strand and pseudomatous bodies among the proliferating meningothelial cells types are distinguished. So in this part, basically the author wants to describe there are two types of sheath meningioma. One of on the basis of histopathology, one is meningothelial, another is the pseudomatous. The pseudomatous have a body, and the meningothelial have a lobules of meningothelial cells separated by a fibrovascular strand. The prognosis for life is good in adults, although the tumor may be more aggressive in children, in whom 25% occur. They are more common in neurofibromatosis type 2 and F2. In optic nerve sheath meningioma, the onset of the visual loss usually occur before the onset of proptosis. So, typical symptoms, diagnosis symptoms typically consist of the gradual visual impairment in one eye, transient obstruction of vision may occur. So signs, there is a very characteristic triad for it. It is a hot Spencer triad. So there will be, first there will be the visual loss, then after the visual loss there will be the optic atrophy, and after that there will be the shunt vessels that will occur after the optic atrophy. So these are the triad that occur in a sequence. The classic Hort Spencer triad consists of progressive visual loss, optic atrophy, and optociliary shunt vessels. Although the simultaneous occurrence of all the three signs in one individual is actually uncommon, the usual sequence of the involvement is opposite to that seen in tumor that develop outside the dural sheath. Uh, optic nerve optic nerve dysfunction and chronic disc swelling followed by atrophy and optociliary collateral 30% which regresses optic atrophy intervenes. So it's like this, that there will be the optic disc swelling and there will be the visual loss due to the swelling, then there will be the optic atrophy that will set after that, and there can be the optic ciliary collaterals as well. Restrictive motility defect, particularly in upcase. Proptosis is one of the common. So there is one other tumor that have a gaze gaze evoked blurring. It is usually the cavernous hemangioma, and it is one of them in which there is a restrictive motility, especially in upcase. CT scan show the thickening and calcification of the optic nerve. MRI is the investigation of the choice. Ultrasonography, especially coronal, may be useful. So, how will you treatment? Treatment may not be indicated in middle-aged patient with a slowly growing lesion, but excision is required for an aggressive tumor, particularly if the eye is blind or there is a risk of intracranial extension. So, basically, these tumors are usually not removed until necessary, because if the vision is good and there is no if the tumor is static, we do not tend, we just observe it. But if the vision is poor and there is a progressive aggressive tumor, we tend to remove it. Attempt at optic nerve sparing surgery commonly fail but may be considered on a case basis. Fractionated stereostatic radiotherapy may be appropriate as a vision sparing approach or an adjuvant treatment following surgery. So sometimes a vision sparing approach is a radiotherapy, which is a fractionated stereostatic, but sometimes it is used with the surgery as an adjunct therapy, surgery plus as a radiotherapy. So this is the figure showing the optic nerve sheath meningioma. A is showing the meningothelial histopathology, B is showing the pseudomatous histopathology, so these are the pseumoma bodies, and C is showing the defective elevation of the right eye. D is showing proptosis, E is showing the axial CT of a small tumor showing calcification, and F is an MRI showing lesion associated with left optic nerve. So next is a plexiform neurofibroma. So plexiform neurofibroma is also associated with NF1. It is basically the uh, sometimes associated with eyelid tumor. It have a characteristic S shape, ptosis and deformity, but sometimes it associated with the orbit as well. So plexiform neurofibroma is the most common peripheral neural or tumor of the orbit. It occurs almost exclusively in association with NF1. Presentation is in early childhood with periorbital swelling. Classically, involvement of the eyelid causes mechanical ptosis with the characteristic S-shaped deformity, but diffuse involvement of the orbit with disfiguring hypertrophy of the periauricular tissue may occur. On palpation, the involved tissue are said to resemble a bag of worms. Very important, bag of worm, plexiform neurofibroma. Malignant changes can occur and should be suspected if there is a rapid change. Radiotherapy may promote this. Treatment is often unsatisfactory and complete surgical removal is difficult. Orbital surgery should be avoided when possible because of the intrinsic relation between the tumor and the important structure. So, basically, you tends to observe this thing, but because the surgery is quite tricky in this case. Isolated localized neurofibroma is less common than plexiform neurofibroma. About 10% of the patient have NF1. Presentation is in third or fourth decade with insidious, mildly painful proptosis, usually not associated with visual impairment or ocular motility dysfunction. Excision is commonly straightforward because the tumor is well circumscribed and relatively avascular. So next is the lymphoma. Lymphoma is a common tumor, but it is usually associated when there is a systemic lymphoma. The lymphoma is basically the we have a B cells and T cells, and there is a B cell proliferation usually in a case of lymphoma. And systemic, it is a systemic disease. There will be the lymph node enlargement, but when it occurs in the eye, it is called the orbital lymphoma. So introduction: lymphomas of the ocular adnexa constitute approximately 80% of the all the extranodal lymphomas. So these are not these are not in the nodes. We have the lymph node, it is an extranodal lymphoma. The majority of the orbital lymphomas are non-Hodgkin, and most of these are 80% are a B cell region. Those affected are typically older individuals. The condition may be primary, involving one or both, or orbit only, or secondary if there are one or more identical foci elsewhere in the body. So it can occur primarily in orbit as well, but usually it is secondary when the elsewhere body is also affected. A substantial proportion of apparently primary lesion will develop disease elsewhere within a few years. So if you are seeing only lymphoma primarily in orbit, so few years later you can see this condition systemically as well. The course is variable and relatively unpredictable. In some patients, histological feature raises the suspicion of malignancy, and yet the lesion resolves spontaneously. So, or with steroid treatment. So, these are one of the uh, lesions that responds to the steroid, but these are very mild response. So whenever you see a patient with the proptosis and you have given him steroid and there is a mild reduction but not significant, you tend to do biopsy to rule out if this is a case of lymphoma as well. Conversely, what appears to be reactive lymphoid hyperplasia may be followed by the development of lymphoma. Small lesion and those involving only the conjunctiva have the best prognosis. So conjunctival lymphoma have the best prognosis, as well as with if the lesion is small. Conjunctival and intraocular lymphoma are discussed in chapter 20. The onset in diagnosis, the onset is characteristically insidious. Symptoms and absence of symptom is common, but may include discomfort, double vision, or bulging eye or visible pus. So basically, there will be the bulging of a mass, and you will see that a rubbery like mass um, consistency like mass bulging from the eye strongly suggests about the lymphoma. So any part of the orbit may be affected. Interior lesions can be palpated and generally have the rubbery consistency. Occasionally, lymphoma may be confined to the conjunctiva or lacrimal glands sparing the orbit. Local lymph nodes should be palpated, but systemic evaluation by appropriate specialist is required. So, it is one of the tumor you must sort the medical specialist opinion as well, or an oncologist opinion as well. Investigation: orbital imaging, usually with MRI, biopsy is usually performed to establish the diagnosis, systemic investigation to establish the extent of the disease. So, biopsy is very important to rule out lymphoma. So, it is one of the tumor that is usually treated with the radiotherapy and chemotherapy. So, radiotherapy is usually localized for the localized lesion, and chemotherapy for disseminated disease, and sometimes immunotherapy. For example, rituximab is a newer modality that may assume a dominant role in the future. Occasionally, a well-defined orbital lesion may be resected. So, the mainstay of treatment is its radiotherapy and chemotherapy. So, this is the orbital lymphoma. A is showing histopathology, showing the neoplastic lymphoid cells. B is showing the involvement of the superior orbit causing proptosis and inferior dystopia. C is showing interior lesion. D is showing the axial fat saturated gadolinium. Enhanced T1 weighted MRI showing a tumor surrounding the right optic nerve sheath and extending to the orbital apex. So you can see the lesion here. Sorry, this one. Next is the rhabdomyosarcoma. So basically, it is a tumor of the childhood, and in which there is a soft tissue proliferation, and mainstay of treatment is radiotherapy or chemotherapy in a case of rhabdomyosarcoma, but you can do tumor resection to reduce the mass as well. So, rhabdomyosarcoma is the most common soft tissue sarcoma of the childhood. 40% develop in the head and neck. It is the most common primary orbital malignancy in children, but is still a rare condition. Approximately 90% of the children under 16 years, and average age of onset is 7 years. So, average age of onset is 7 years. The tumor is derived from the undifferentiated mesenchymal cells that have the potential to differentiate into striated muscle. So it is basically the proliferation of the mesenchymal cell that differentiate into the striated muscle. Various genetic predisposition have been identified, including the variant of RB1 gene responsible for retinoblastoma. 4 subtypes are recognized: embryonal, alveolar, and botryoid, and pleomorphic. So basically it is very common because embryonal is majority of the cases, whereas alveolar makes the worst prognosis. So embryonal constitute the majority, 85% of the orbital lesion. Cell may show light microscopic features of the striated muscle differentiation. So more the differentiated tumor is, the more it has a good prognosis. So embryonal usually carries a good prognosis. Alveolar make up most of the balance of the orbital RMS. Few cells show skeletal muscle differentiation than embryonal, and the prognosis is worse. Particular chromosomal translocation are characteristic on cytogenic analysis of biopsy material. Botryoid 4% pleomorphic RMS are much less common in the orbit. Rhabdomyosarcoma can mimic an orbital infection in a child. So, how are you diagnosed? Symptoms: rapidly progressive. Unilateral proptosis is usual and may mimic an inflammatory condition such as orbital cellulitis. Signs: the tumor is most commonly supranasal or superior, but may arise anywhere in the orbit, including inferiorly. It can also arise in other tissues such as conjunctiva and uvea. So, it can occur in any part of the orbit. Swelling and redness of the overlying skin develop that the skin is not warm. So it mimics the infection because there is a swelling and redness, but the lesion is not itself warm. Diplopia is frequent, but the pain is less common. Investigation. So MRI will show the poorly defined mass. CT scan show a poorly defined mass of a homogeneous density, often with the adjacent bony destruction. So there will be the bony destruction as well, because it is a malignant tumor. Incisional biopsy is performed to confirm the diagnosis and establish the histopathological subtypes and cytogenic characteristics. Systemic investigation for metastasis should be performed with lung and bone being the most common site. So it is a malignant disease, so it can spread to the lung and bone as well. Treatment. Commonly used guidelines for the staging and corresponding treatment protocol were produced by the intergroup rhabdomyosarcoma study group. IRSG treatment encompasses a combination of a radiotherapy, chemotherapy, and sometimes surgical debulking. So you do not do the surgery to remove the tumor, but you basically do to debulk the tumor. The prognosis for patient with disease confined to the orbit is good. So these are the pictures. These are the rhabdomyosarcoma is showing histopathology, showing a differentiated tumor in which the rhabdomyoblast in the center of the field has a cross striation. Missense trichome stain. B is showing the superiorly located lesion. C is showing anterior-inferiorly located lesion. D is showing the CT scan showing bony destruction and intracranial separate. So these are the tumor. So that's it for the orbit. See you in the next lecture.